Welcome to Subject to Interpretation, a podcast which takes us deep into the subjects that matter to professional interpreters. I'm your host, Maria Ceballos Wallis. Have you ever needed to take a break between interpreting encounters? Have you ever found yourself in an interpreting situation where you were so exasperated that you wanted to leave the encounter because you couldn't concentrate? Have you ever left an interpretation encounter thinking that your memory skills and accuracy had been compromised? Well, I know I have. So today we're going to go deeper into interpreter fatigue and its relationship with vicarious trauma in our continuing conversation with Andrea Henry. She's a medical interpreter and researcher spearheading interpreter productivity research using the CFIE tool, which studies complicated encounters and interpreter fatigue. Andrea has been active in healthcare interpreting for more than 25 years. She has worked as a full-time, remote, and in-person medical interpreter, and has also had several positions as an interpreter coordinator. She's also an interpreter trainer and has presented extensively on measuring interpreter mental fatigue. She joins us from Atlanta, Georgia. Welcome back to Subject to Interpretation, Andrea.
Thank you. It's a pleasure to be here. I really appreciate this.
Well, last time you were with us, we had a very interesting conversation regarding the research. So what does CFIE stand for?
So you can call it the CFIE. You can also say CFI. It's an acronym, and it's complexity and fatigue and interpreted encounters.
Give us a general overview of its purpose.
We're an interdisciplinary research team at Children's Healthcare of Atlanta and Emory University. There's me as the principal investigator, and then Kathy Murphy is my co-investigator. She's a clinical nurse specialist in the cardiac unit at Children's Healthcare of Atlanta and congenital cardiac defects. And then also Dr. McCracken from Emory. Previously, she's at Kaiser now, and we're working now with Scott Gillespie from Emory. But the tool that we developed and validated was initially intended, like I mentioned on the last opportunity I had to share on this podcast. It was initially the idea behind it came from an email from Natalie Kelly on the NCHC listserv, just asking people to share about workload and productivity. And that's where all of this came from. So the initial drive was to find a way to quantify workload for interpreters in the healthcare setting. There was an awareness that we really had a very basic way of looking at productivity that wasn't really reflecting the actual work itself for the interpreter. So that's where we started. And that was back in, 2009. When we officially started working. And then in 2010, we got a grant from a vendor, a no strings attached grant. And then we started working on getting the content for the tool. So whenever you create something like this, you work with the actual users, like the people that will be using this. So interpreters participated in focus groups and an anonymous survey. And that was how we confirmed the content for it. And then we went through various stages, which I can talk about depending on what you want to know. But we did an internal validation phase at Children's Healthcare of Atlanta with a total of 24 interpreters, all face-to-face, all Spanish. And then we did a second phase, an external validation phase at 3 separate hospitals with 8 different languages and doing all 3 modalities, face-to-face, phone, and video. And we've completed the research at this point.
So before we go on to talk about the research and the results, I think it would be instructive to give an overview of the many factors that can trigger fatigue or stress while working as an interpreter. So I have a couple here. Maybe you could add some. Obviously, the setting, the type of setting, whether it's a high stress setting or not. If you're in an ER room or a triage, it's probably different than if you are just I don't know, sitting in a mall and have to interpret for someone is probably a big difference.
It can happen.
The topics, the persons you're interpreting for, and of course, how they are feeling and how they are also reacting. paralinguistic or linguistic factors, any cultural, moral, or ethic factors on behalf of the interpreter who, may not be sure if they should say or shouldn't say something because of the culture of the person they're interpreting for, and many more. Would you like to add any to that?
What I could do is share that what we ended up finding with the content or the information we got from the interpreters who participated in that process, the 4 focus groups and then the anonymous survey, was that we found that many of the demands on concentration, which is one way to look at it, sort of fit within 3 categories, which is a model that already existed. Robin Dean and Robert Pollard have done research for years and have done training for years in the sign language interpreting community. And they used an occupational health model to look at the things that need to be, or the way interpreters need to be trained. They need to anticipate the reality of dialogue and the reality of interpreting. And for us, I suppose in healthcare, it is almost entirely dialogue, but the things that people do and how they say it are unpredictable. The way people manage the content of what they're either sharing with the other party or the way they're receiving it is unpredictable. And so we found that looking at the model that they used for training was very much where these interpreters who had participated, where the information they were giving us, it fell within 3 categories, which were paralinguistic, the way people express themselves, and then also environmental, just the actual characteristics of the room you're interpreting in. For example, like you mentioned, a mall, it could be very loud, so you have these secondary noises happening outside of the fact that you're hypervigilant to what is coming out of that person's mouth and for the length of time it's coming out, and in all its glory, the cadence with which they speak, the speed with which they speak, the accent with which they speak, and whether or not they're coherent. All of those things impact an interpreter's ability to perform. And then but the environment, of course, you could potentially have very disruptive environments from the standpoint of noise or smells or visuals. And then the other category was intrapersonal, which was the way Robin Dean classified it. Our initial title, I suppose, for that particular section of the tool was emotional. We didn't really have the appropriate nomenclature. And so it was wonderful to see that a model existed, at least for those 3 areas. The actual demands on concentration that came up with our development process were unique to healthcare interpreters in this type of setting, but it gave us some way to structure it. And within that last section is very much, though I didn't know the term at the time, it's very much within the realm of vicarious trauma. So interpreting for poor prognoses, bad news, hostility.
Tell me a little bit more about vicarious trauma in terms of the tool. So you didn't really know you were measuring for vicarious trauma, but in fact you did. How did that come about?
Well, the actual content came through that development process, and then I would have to give Ludmila Golovin credit for engaging me, and I don't have a specific date when I first spoke with her, but she's really, with all the work she's done out there and with her understanding and her expertise in this area, I think on many levels I realized, okay, I didn't call it this. I was thinking in that very sexy title, intrapersonal as opposed to interpersonal. So intra is what's going on inside the actual interpreter while they're trying to channel these messages. And so I think with Ludmila's work on it and seeing her present both live and seeing her webinars, it's become more clear to me, and with my opportunities to engage with her, that the tool has this section on it that just happens to be within that category. Though I didn't know it at the time, it was just considered, that section. This is what the interpreters have told us. This is what we've looked at. And now we have a bit of an alignment with some of the work that Ludmilla and Masterword are doing to get the word out that interpreters are dealing with some incredibly traumatizing encounters, and we're really not addressing it as a field. And her work is hopefully gonna push that forward.
The project involved essentially two major phases. One was the internal validation of your data, which we talked about in our last podcast. And when we spoke that time, you were in the process of beginning the external validation by training interpreters at Cambridge Healthcare Alliance how to use the tool, and you were also starting to work with several other hospitals. Tell me about the number of people involved and the logistics around working with, several hospitals.
Absolutely. So yes, when we talked last, Cambridge Health Alliance had signed on, and that I have to give Vanessa Costa credit always, not for just being willing to sign on, but being willing to wait, because we did receive a large grant to do this second external phase, and we had to stall because of the pandemic. And so when I spoke with you last time, we had Cambridge Health Alliance already signed up. And we thought two other hospitals were going to sign up because their management were also supportive. It's an important thing to think about. A lot of these interpreters that signed up because their managers said, okay, I want to do this. Let's see, what's the worst that can happen. Maybe I'll find out that my interpreters are mentally fatigued. And we need to maybe address it. And so it's a wonderful thing to have managers say yes to this. But in a couple instances, we just didn't get enough interpreters to sign up. And we did have a limit, or at least a threshold that we wanted to pass. And we needed at least 10 people. And in the end, we had Cambridge Health Alliance, Cincinnati Children's, and University Health System of San Antonio. And so we had 8 languages represented in those 3 different facilities, very different facilities. So a wonderful amount of data when you think about it. It's very, very diverse, having different language pairs, having different types of settings, children's settings versus adults. And then also the aspect of all 3 of these hospitals, they all happened to have interpreters who were doing all 3 modalities. So the tool was able to be tested in face-to-face video and phone by the very same interpreters. So that was very exciting. And when we followed the same methodology that we had at Children's Healthcare of Atlanta, we gave everybody a 1-hour training on how to use the tool to get them all prepared to use it on their own. And we had digital versions for each one of those facilities. So they used a digital version of it. Back when we did it the first time at Children's in 2018, we gave the option to the participants. So they voluntarily participated, staff interpreters, full-time, part-time, and PRN and per diem. But all of this very much is a process where people agree to do something that's going to take a little bit of effort on their part. So it's something to be very grateful when you have people say yes. So they, that first group at Children's, some of them did use the paper version and then input the data in the database. But by the time we made it to external validation and COVID had hit and the pandemic was in full force, we did all of this virtually, which the money that I had gotten from that grant from the Dudley Moore Foundation for Nursing and Allied Health, healthcare interpreters fit within the category of allied health, right up with physical therapists, occupational therapists, nutritionists were in that category. So we were eligible, and it was a competitive process, and we were very excited to get the money, but the money ended up shifting to a virtual process, which was a silver lining in the end, because it made it possible for us to do it all, which I'm not sure if I had flown to all of these cities, the money would have been enough. So it worked out really, really well. And so in the phase at Children's Healthcare of Atlanta, or the 2 phases we had, we got approximately 1,600 interpreted encounters, which means that 24 interpreters used the tool following their interpreted encounter 1,600 times. So it's a lot of data. It was very exciting. And then when we did the second phase with Cambridge Health Alliance, Cincinnati Children's, and University Health System San Antonio, we had 43 interpreters representing 8 languages using the tool in all 3 modalities. And they got roughly 2,300 completed CFIE tools. So that means that we had a very large amount of data to see if the patterns were the same, or to see if the tool performs.
So before we get into what you found, tell me a little bit about the process that the interpreter has to go through in order to use a CFIE tool.
Sure. It's one of the limitations of this particular type of tool, and it's pretty much related to the fact that interpreters don't have extra bandwidth to be, interpreting, listening to what somebody says for, 5 to 8 sentences, maybe very technically complicated, and all of these demands on my concentration are happening, and then somehow be like, okay, let me fill this out while I'm actively working. We can't do that because of the nature of an interpreter's job, which is pretty unique. There's nobody else in the entire hospital who is that hypervigilant in terms of having to hang on every word that somebody's saying and make sure you don't miss a beat, and memorizing it all, and then converting it into a whole other syntax and a whole other phonetic system, and all the different cultural layers. But so that the reality of the job is such that the interpreter fills out the tool right after finishing the interpretation. And the limitation is pretty much the fact that it's all related to recall. So when you step out, ideally, you should still remember everything that you dealt with from the standpoint of disruptions. And so you fill it out when you step out. It's very binary. It's yes, no. It's very objective. The whole process we went through with Dr. McCracken, our statistician who helped in that particular phase, she made sure that the design of the tool was not only simple, but also met the requirements of a tool from the standpoint of good performance. It has to be as objective as possible. Otherwise, you get answers that have more to do with the person than the reality of the interpreted session. So that was painstakingly done. And so the interpreter fills it out digitally, either on their cell phone or an iPad, and they just, hit submit, just like any kind of survey you might do, for some healthcare system when they're asking you how your appointment was last Tuesday. It's very, very straightforward. And then the process that we've gone through with development and validation has also yielded some understanding of some of the more impressive numbers with certain demands. And what that means is that the scoring process, which will be sort of behind the scenes, like an interpreter will fill it out, but ultimately the measurement will have a score, which is ideally what a manager would be able to use to flesh out the productivity numbers that they're currently getting that don't look as impressive as they should. So it's another layer to the workload quantification.
Now, you mentioned that there was a category for, I guess, questions that have to do with emotions. What are the other categories that you inquire about?
One of the domains or one of the sections is a paralinguistic. So essentially how people engage with each other, and how the interpreter has to manage either traffic control, making extra decisions. Do I stop this? Do I clarify this? Did I miss this? From the standpoint of what it's like to be between, at the very least, 2 people who are communicating, and potentially communicating in a rather messy way, just because we're all human, which I think is something we don't often think about with healthcare interpreting. Like I mentioned earlier, it's dialogue. It's not a controlled setting. And, when we're doing conference interpreting, it's mostly academic or could be geopolitical, but there's something very controlled about it most of the time. Even in a courtroom, I suppose, when you're doing simultaneous, you may have the awareness of what the information already is going to be. So it gives you some advantage to predict. And that goes a long way to good performance. With interpreting in healthcare, there's nothing about anything I can predict. I could walk in with the same players 5 days later, same provider, same mom, but the engagement and the way they speak to each other could be very different today than it was several days ago. So that section is looking at that, and then the environmental section is looking at the demands on concentration for the interpreter based on the location itself. What kind of disruptions from an auditory standpoint or from a visual standpoint are impacting the interpreter's ability to concentrate.
Now, you make a very good point with regards to the dialogue and the unpredictability of it, because I'm thinking right now that in court, for example, if one is interpreting consecutively, which is the dialogue, for example, for a witness on the stand, an attorney would never ask a question they do not know the answer to, or that, if you're doing the first questioning, and then it could get a little more tricky when you have cross-examination. But in general, it is far more controlled than I would imagine a medical encounter would be, especially one that is in that has high stakes, where getting information quickly is of the essence, or where maybe the person is in a high pain threshold or something like that, right?
Mm-hmm. Absolutely. Yeah, I think that's something we often we don't talk about as much. I think we're talking about it more now, but I mean, we're dealing with people in some of the worst days of their lives. So, and we're also dealing with providers in some of their worst days as well, that they don't want to be saying the things that they're saying when someone's diagnosed with something, either life-threatening or something chronic that's going to change everything about their life, their mobility, their ability to work. All of those things are part of our job, and it's pretty impactful. There's so much about what we're doing that just inherently becomes a mental health kind of dialogue, because and it's not ostensibly mental health. I'm not going to this appointment at 2 to interpret for a psychologist and the parents of a child who just got diagnosed with cancer. It's not really that at all. Most of the time, it's that I'm in a room, I'm interpreting, and things come up organically or naturally, and it becomes very much you have this window into this moment. In addition to the fact that you're hypervigilant, you're trying to memorize everything that somebody's saying and then convert it without missing a beat into the appropriate language and all the various layers to that. But you're also aware of these moments in someone's life that they're hearing with your voice, especially when the direction of it is coming from the provider, sharing information that they don't want to share because it doesn't feel good to say that to anyone. And then I get to say it. And it's my voice that they remember. And it's my voice that they may unfortunately associate with that moment. And those things happen all day long. And when it is ostensibly a mental health encounter, and I know it, then I'm maybe prepared for the fact that this might be 60 minutes of all deep conversation, as opposed to some concrete information being shared and then feelings being expressed and devastation, and then more information being shared. And that happens sometimes, and you're not really prepared for it. Though I would say, working in healthcare, it would be wonderful if we were given more training and more opportunities to recognize that most of these appointments they're not good news appointments. They're mostly either people stressed out and hoping for good news, but still really anxious because they've gotten bad news before, and then they're cured, and now they're just spending the rest of their life worrying that there's going to be a relapse. But most of what we're doing in healthcare is dealing with people in some of the hardest times of their lives.
So I'm wondering if the interpreters who use the tool evaluated their encounter differently if it had a positive outcome versus a negative outcome. Do you have any thoughts on that?
Well, I don't know. I'm sure there's all kinds of anecdotal evidence. The tool is meant to be as concrete and objective as possible. And in fact, with the interpreters that used the tool at Children's and at the 3 external sites, we asked them to use the tool in non-demanding encounters, like the ones that you walk out and you think, oh, that was perfect. Everybody followed the rules. The information that was asked for was given. People gave me appropriate pauses. I didn't feel like I was being pushed beyond my performance limits. We said, okay, use it for that as well. Use it for everything, a wide variety. So the information we got was related to how demanding or non-demanding, or how much cognitive effort was required for the interpreter, and then of course the resulting mental fatigue. But we don't really have the information about the feel-good stuff. But I could tell you personally that getting to go in a room and give good news is very energizing. And so I think on that level, for me personally, which is too subjective to measure, I know that certain things give me energy. So when someone says, oh, I just have a couple things to tell her, it's really, I'm sorry to call you. I know you got more important stuff to do, and I just want to tell her that the test results good. I'm like, oh, I love it. Absolutely. Don't be sorry. Coming to do this, even if it's just 5 minutes, will balance my day for me. It'll give me a moment to be the vehicle by which this mom learns of good news. And it might be just 5 minutes, but it'll probably fill my gas tank, at least enough to manage the next assignment that may not be as positive. So yeah, I know anecdotally that means a lot to me, but those pieces are a little subjective, and all of us are a little unique about what energizes us or what we perceive as easy, outside of the demands that we actually measured.
Now, did you find that any type of specific encounter was more taxing for interpreters than others in different departments or areas?
Yes, that was really interesting. And I hope that people listening to this that want to do research might enjoy this piece, because there's an aspect to research that if you just keep your mind open and you think, I don't know what people are going to say. I don't know what I don't know what the results will be. If you keep an open mind, then the results, when they surprise you, will be kind of fun in the sense that you're not expecting it. But we did have, so in the process of doing the external validation with those 3 facilities and the 43 interpreters that spoke Arabic, Cantonese, French, Mandarin, Portuguese, Spanish, and ASL, and Haitian Creole, we had no idea what to expect, especially with phone and video. I did full-time phone interpreting in the beginning of my career in 1994 at Pacific Interpreters at their headquarters in Portland. And I don't really remember much, except I realized at that point I loved a team. I had never had a team. As an interpreter, we're pretty lonely. And this was way before like cell phones. I had a paper dictionary. I mean, there was just no engaging with people really. And I realized when I was doing phone interpreting that as much as I missed the environment and certain characteristics about interpreting in a clinic setting, or a hospital, I loved the fact that I suddenly had a team, because I could like hit the mute button and scream out and get like a dictionary response from all my colleagues instead of having to dig around looking for it. But the assumption or hypothesis was just non-existent in terms of what would be fatiguing for an interpreter, or more fatiguing with those 3 modalities. And what we found was that out of those 2,300 encounters with the 3 different hospitals and 43 interpreters, that at all 3 facilities, the video interpreting was severely fatiguing. That was a surprise. I had no idea that it would be that different, and I certainly didn't expect it to be severely fatiguing. Phone interpreting for those same interpreters was less fatiguing than video, and face-to-face was the least. So when we looked at that, it just took a while to process it. And I have no idea really why. I've had anecdotal evidence type conversations with colleagues that do this type of work, but we haven't really been able to tease it out of the data. We haven't deliberately looked at that yet. It would be interesting if we could. But the fact that it was so severely fatiguing was a surprise, almost in the same way. And I think I shared this on the last interview, that the pre-session, which was just a question, it's really not a key part of the tool, but it was a curiosity. We thought, well, let's see, they tell us to do a pre-session. We all do a pre-session. Does this make a difference? Do people communicate better? I guess from that standpoint, the pre-session has many purposes, but one of them is to ask people to, allow you to interpret, which means please help me not have to do so much traffic control. Please give me pauses every few sentences. And what we found was a surprise with that too, that at least from the data from Children's Healthcare of Atlanta, those 2 different years, 2018 and 2020, with 24 interpreters, the pre-session did not yield less fatigue. It actually was associated with more fatigue when they actually checked, yes, I did do a pre-session for this particular assignment. So that was another surprise. But that's the beauty of research, is that you learn things in the process and you don't always learn what you think you're going to learn. And that's refreshing.
As far as the pre-session is concerned, I believe we talked about the fact that some people use pre-sessions when they think they're going to have a problem, as opposed to generally all the time.
Right. And that was one of the potential explanations for that data, which again, we don't have a for sure answer or certainty about it. But the idea, and of course, everybody that got trained on the tool also received the specifics of a pre-session. If you use these particular pieces for your pre-session, then you could say you used one, because we tried to standardize it in that regard. But yeah, there was the potential, that we don't have proof, but it made a lot of sense, was like, most of us tend to get really very deliberate about a pre-session when we know nobody's going to do what we need them to do, because the environment is loud and messy, or there's 10 people sitting at a table, all of them wanting to talk, and then of course the parents. This is a children's environment, so that data was from potentially those kinds of environments where you've got the parents of a child in a room with a lot of providers. But that was our assumption, like that might be the explanation to why, when interpreters said they used a pre-session, there was higher fatigue, significantly higher. But we don't know, but it sounds intuitive. It seems logical.
Regarding your results for the video interpreting, the VRI, is it possible to reach some kind of conclusion or make some generalizations about which type of encounters should not be handled via VRI, which, depending on the type of subject matter or the type of encounter, it just further compounds interpreter fatigue?
So what is very interesting, a couple of the hospitals that participated in that phase, so the 43 interpreters at the 3 different hospitals, 2 of the hospitals took that information, because they all got a presentation from us when we had the data analyzed, and then we shared it with them. They made changes, but it was more about the workflow. They made changes because with that information from a very large chunk of their team. So at Cambridge Health Alliance, they have over 100 interpreters, I believe, and we had about 24 participate from the team. And then at Cincinnati Children's, their team isn't quite as large, but we had 11 interpreters participate. And then University Health System San Antonio had about 10 interpreters participate, maybe a couple less. Maybe we needed 10. I think we ended up with 8 or 9. But what they ended up doing was using face-to-face as an intervention, or thinking, okay, if video interpreting is causing this much fatigue for whatever reason, we would like to help our interpreters not feel this level of fatigue, which I think is really very much from the recognition that fatigue yields mistakes. In every service line in the hospital. That is a very clear awareness. And there's so many strategies that they have for nurses, for example, ways to reduce distractions so that their performance as a nurse, from the standpoint of administering medication, the right dose, the right medication, they have all kinds of strategies to reduce disruptions so that they don't make mistakes. Plus, they also have staffing models that try to control fatigue so that they also don't make mistakes. So with us, as interpreters, we have the same goals. We would like to perform at our best, and not make mistakes. This is people's lives. We're not selling hamburgers. And so what they did was they said, okay, let's fix this. Let's get more interpreters back to face-to-face, because they're all doing all three modalities. So that was one of the really wonderful outcomes of this, is that they made changes and they made them really quick. And they sat down with their team and looked at other aspects of what is needed to control fatigue better, so that performance is better and so satisfaction is higher. And they, in addition to doing more face-to-face and releasing them from as much VRI, they also looked at aspects of their workflow that were stressful or wasteful. And they shared that with us. And I think it is just really just incredible for me to realize, even though the tool's not out there yet and being used across the country, which we would like, and it is free, but it's not out there yet. But these hospitals that participated have made changes. And another one also is that they expressed that they are now talking to their team and saying, how is your day going? How is your fatigue? How is your stress level? And just having those one-on-one conversations, which is very much part of not just improving the dialogue around it, but it makes interpreters feel valued when their management sits them down and says, I'd like you to feel better. Is there something about today that could have gone better? Is there a way that your workflow would have allowed you more breaks? Did you get the breaks you needed after assignments that were particularly demanding? That's huge. And just to have that terminology for people to actually know how to express those things, as interpreters especially. And that, I think, is the other outgrowth of this research, that, again, despite the fact that the tool's not out there yet, there is more dialogue around it, and especially on our team at Children's Healthcare of Atlanta, and then at these other hospitals, they're already making changes. And so I think, and I think this is probably a good point to mention. I think a lot of people think the tool is measuring burnout. The tool is measuring the demands or the cognitive effort in each individual encounter, which allows a manager to not only corroborate or confirm a more sophisticated and rigorous productivity, or something that actually shows the true job itself and the cognitive load and effort that interpreters are dealing with. But I think it also, like I mentioned earlier, it helps them justify positions because they can actually show that this is the true productivity of my team. But it's, I think if you don't control it, certainly you will end up with burnt out interpreters, and you lose a incredible amount of talent when people get burnt out. So if you use the tool to control the fatigue, you've got happier interpreters, and then they won't end up getting burnt out and leaving. And that's a loss of revenue. It's an incredible loss for a facility to have a talented interpreter they've spent thousands to recruit, more thousands to orient. And then when they leave, maybe because their workload was not controlled and their working conditions were substandard, you lose quite a bit of money as well. And so there's a good case from a business standpoint for looking at these things. But I think I'd like to point out, it's not a burnout tool, and it's not really a self-care tool per se, but all of these things are related. So I think what those three hospitals have done is pretty impressive. They took that data and they made changes, and I think that's a bit of an unexpected bit of beauty, I suppose, for me.
Backing up a little bit, you mentioned that hospitals are very concerned with employee fatigue, regardless of whether it's the interpreter or not, and the nurses, the doctors. And I recall speaking with you about the fact that they have a model about acuity of encounter, and that's how they measure whether or not, how to do staffing, perhaps, and that you have taken that information and kind of used it to inform the CFIE tool. Now, there's also other kinds of, I guess, other tools that are being used in hospitals, such as, for example, trauma-informed care, or creating or dealing with patients with from a different paradigm, perhaps. Can you talk about that?
Certainly. I think with staffing models, which is just a term that's used, by different departments in a facility that are trying to figure out a way to have enough of this type of worker so that care is given and no corners are cut. Nobody makes mistakes. Staffing appropriately is the goal. To have enough nurses for these kids or for these patients, and not too much and not too little. And obviously looking at it from the standpoint of you get better performance from anybody if their working conditions are appropriate. And part of that is the amount of workload they have, or with nurses. And the example I always give is that the ICU is staffed very differently than a clinic setting. There's one-on-one care in an ICU, and in a clinic setting where everybody's quite healthy and stable, there's not one-on-one care. You've got more patients per nurse, but there is an effort right now. And again, Ludmila Golovin is working on it too, with other experts, to try to get hospitals to or facilities really. And I think looking at it from a standpoint of language service providers, to get them certified as trauma-informed facilities. To think about it from the standpoint of, there's a billion tools in healthcare, certainly, but there's also a lot of endorsements that every hospital is trying to get, like Joint Commission or Magnet, things that show that you are exceptional, and that people would want to go to your facility over another facility. And trauma-informed care for me is another new concept. And I became aware of it last year when working with a family at the hospital who not only had a lot of trauma in their background, but were also dealing with repeat trauma because of, and trauma in the general sense, right? Just really, really rough times, very difficult situations to be dealing with. Whether or not that's illness, death, or of course, like most people think with trauma, I think some people think of it like a car accident or something, but a lot of people's trauma is also includes abuse, rape, just coming from war-torn countries. But the family had made a request, and the social worker had said, well, in a little hallway conversation, she said, absolutely, that is one of the biggest things we need to do for trauma-informed care. And I said, what is that? Tell me more. And she said, well, trauma-informed care is what a lot of us are looking at right now. I think the social workers are probably ahead of the game, but that choice is key. So giving a patient choice, and it seems so obvious, but those are aspects of trauma-informed care, so that you don't re-traumatize somebody, so that you don't put them in another situation where they're experiencing some kind of anguish, and we don't need to. And so this parent had made a request, and the social worker pushed to make sure that request was honored. And then I started looking at trauma-informed care and realizing, oh my goodness, this is applicable to an interpreter's work as well, from the standpoint of recognizing that we need to be aware of all of these aspects of appropriate care for patients. And we should be a part of that process. Like, we should be collaborating with providers to make sure that, some element of this patient's past or whatever they're asking for right now, if this fits within that model, we have very much the leverage to do it. And why aren't more people talking about this? And I think, like I said, with Ludmila Golovin from Masterword, I think she's making quite a big effort to get this out there as well. But I think it's a really good thing for interpreters to think about. And also for us as interpreters, we also have to think about the kind of trauma we're experiencing from a vicarious trauma standpoint. If we're unaware of the things that can potentially re-traumatize us or trigger us because of our own life, the things we've suffered, the things we've seen, the things we've dealt with. If we're unaware, we're not going to be our best selves in those moments. And I think learning about it from the patient standpoint can be perfectly applicable to what it means to an interpreter to be better prepared for these kinds of situations that could potentially be more difficult and damaging to an interpreter than they need to be.
So what would trauma-informed care look like from the perspective of the interpreter?
Well, I think my best example, and I'm not an expert by any means, it would be that, recognizing if a patient says, for example, you're walking out of the room, doctor's already left the room, you're on your way out, and you're saying con permiso, or, letting them know you're on your way out and you'll come back if they need you. When they say something like, oh, hey, can you tell me what I should do? The nurse last night was, she was really gruff and she kept me in the room. She kept turning the lights on and she was really not very nice to my child. And I don't want her back. So from the standpoint of advocating for what she needs, that's there. And that many of us know that that's our role to say, well, let me get the nurse. I'll have, the nurse, a different nurse. Let me get, or a charge nurse. Let me have her come in and see if she can talk to you and I'll interpret the conversation. And that right there, on the surface, might seem like a general idea of advocacy in the sense that mom has made a request. I was the only one that heard it. I'm going to go find the person that can address it. And I'll be the person that relays this back and forth between the two of them. But she also made a request that I'm aware of. So every single time I come back to that room, if somebody forgets and I'm aware that, Nurse Susie is really not a good fit for this mom and she has suffered and it's bad enough that they're in the hospital for this reason, but to have a nurse not be kind or to see that, we don't want that to happen. And they do have the opportunity to switch nurses. And so I might advocate for that. I might, if I realize that they've accidentally scheduled this same person, I might, in the hallway. So this is Andrea talking here. I did interpret for a conversation where mom had requested this particular thing or had asked for this particular nurse to not come back. And so I'm honoring her choice and her ability to have agency. She needs a voice. She's used it. I've been now relaying what she's asked for, and then I could advocate for it in the sense of, again, choice. So for me, trauma-informed care at this point, and it's very limited, is mostly for me, I'm thinking about it from the standpoint of honoring that mom's choice. Or if she says, I do not want anyone to use the word cancer in front of my child. That conversation is a conversation I want to have, and I don't want you guys to use that, or please don't use the word relapse, or please don't, whatever word she said, I'm there, I've witnessed it because I've been her interpreter, but you'd be amazed at how quickly things like that get lost. They report with each other and it's in the chart, but somebody comes in and they may have forgotten it. And so I could potentially also advocate for the fact that mom made that request. And at the doorway, if I'm with somebody new, and say, listen, before we go in, just so you know, I've interpreted for this mom before she's made the request to please not use that word in front of her child. She's waiting to have that conversation with the psychologist or a child life specialist. And so I can advocate for that. And that is very much in alignment with trauma-informed care.
And what about if a family requests the same interpreter more than once, for example? Is that, does that create any type of conflict of interest in healthcare interpreting, where now you've developed a relationship, or they believe that they've developed a relationship with you, they feel more comfortable with one interpreter versus another?
Yes, that's a really interesting question. This is my 27th year in the field. And when I started, I was at Pacific Interpreters. And back then in the 90s, and technology was non-existent in the way it is now. And you would get set up with the same person like over and over again, especially for pregnancy and then delivery. So I had many moms to be that I would get to go to every single one of their prenatal appointments. And I still remember this one mom. It was the sweetest thing. She went in and I was there interpreting. She was supposed to do a urine sample. I guess that's pretty typical, and she went in and she stepped out. She's like, I forgot to fill the cup. Like she went in, she peed, but she never did the, like she had to pee. So, and I just remember, and it was the sweetest thing, but I went with her with all of her appointments. And then for the delivery, I was there. And that's how we did it back then. But over time, there's been this shift in the field, which is more about the business approach, I believe. And I thought I was unique to noticing it, at least in spoken language interpreters. And there being sort of a hesitation around sending the same person. Or, I was on a panel a couple of years ago, and it was actually the educational environment, and the person on the panel seemed very skeptical about why an interpreter would be requested. And I thought, oh gosh, there it is again. And then on a sign language panel that I got to watch with Robert Lee and oh goodness, not Dr. Herring. I'm drawing a blank. He's a cancer survivor and a professor in North Carolina, and he's deaf. And he also talked about this issue. And I thought, there it is, that as a patient, so he's deaf and he uses a sign language interpreter, and he, shared that he's a cancer survivor, and that as a patient, once you align with an interpreter and you have that sense that you have lexicon alignment, right? We're speaking generally the same language, or you've gotten used to my language as a patient. So say I'm the patient and say you're my interpreter. If you've gotten used to the words I've used, you've asked me for clarification a few times during these 2 hours, and you're on, you've got the words. And I feel like, okay, Maria knows what I mean because she's asked, and now she's adopted that word, and it's going to be translated, interpreted correctly. There's an alignment that happens with lexicon, but there's also an alignment that happens because of who we are. And so there's something about you that I might be quite comfortable with, not just because you've been there, but there's something about the way you're interpreting for me that allows me to have a voice. And so what's fascinating about it is realizing, this is happening in many aspects of our industry, but I think it's mostly happening because in terms of people wanting to control it and say, I can't send you the same interpreter every time. That's just not going to be feasible from a business standpoint. Or, on a team of interpreters at a hospital, I can't send you the same person because she may not be here. And a bit of a reluctance to do that, with the assumption, like you mentioned, that maybe the interpreters created a relationship or some sort of a relationship that goes outside the scope of practice for interpreters. And that piece I do hope we can work on in the future in the field. And Robert Lee does talk about this in Role Space and Llewellyn Jones. It's a wonderful book on interpreter practice and thinking about it from the standpoint of alignment. And there are things that you do that you may or may not create alignment with for that family. And there are certain interpreters that meet the needs of that family for whatever it is that they need. And so if you've got a really rough care conference coming up, for example, which is the term we use in healthcare for let's sit down, everybody's going to be here, every single specialist, the patient's caregivers or the patient themselves or the parents, and we're going to talk about where we're at. And sometimes it involves really rough news. Like we've run out of ideas, we've run out of treatment, we have no options. Those are pretty tough conversations. And when a family has had them enough and has been in a hospital for enough time to recognize that there is an interpreter or a couple interpreters that they align with better from the standpoint, again, of lexicon, from the standpoint of the tone of voice, maybe gender. There are many things, and maybe accent. There are many things about an interpreter that are quite visible to the patient or the parent. And I think we have to recognize that in this work. And if there is an opportunity to honor it, we should. And many times at Children's Healthcare of Atlanta, we do. And I would hope that other hospitals have this opportunity to look at it from that standpoint. And we have several kids, over the years that have made requests or their parents for big care conference kinds of moments. And that's the least you can do, is honor that request if you can. If that interpreter's there that day and they also want to be there, like it's a perfect alignment of, what both sides want, then it's the best way to keep that mom from experiencing any more grief than she has to, or the patient any more grief that they have to. We have these opportunities, and I think it's a wonderful thing for us to start thinking about it from that standpoint. That interpreters generally, if they're working within their scope of practice and they're following their ethics, they've just created a beautiful alignment, but not necessarily relationship. I mean, some
So,
people don't even know our names, but they still want us to be that person, to be the interpreter. And that's a compliment. It's a huge compliment.
so from the interpreter's perspective, job satisfaction, the satisfaction of, there's different levels. There's, macro, all the way down to very personal. The satisfaction of knowing that you're there to provide language access to someone, and moving all the way down to feeling that you're actually a valued member of the team, that you are not just a tool that that's standing there, that you could be replaced by Google Translate at any moment, or AI. Talk a little bit just in general about how all these things seem to be coalescing to perhaps give the interpreter not just more of a professional standing, but perhaps also create a balance where job satisfaction and accomplishment are part of the entire equation.
The research for us, Children's Healthcare of Atlanta and Emory, started as a desire to create a metric to look at productivity, like a more rigorous way to assess what workload is for interpreters who are, I would argue, doing mental gymnastics all day long and memorizing large tracts of information repeatedly. I don't think anybody could do that just in English all day long without going home and sleeping for the next 3 days, but we somehow do this. But I think that there's an awful lot that's come out of the research that went way beyond that initial idea, thanks to Natalie Kelly, of creating a metric. And some of that is, like you mentioned, satisfaction. How do we improve an interpreter's satisfaction, either at a hospital, which I would argue there's a lot of privileges of working in a setting like a hospital in many ways, but also for freelancers. And what about our remote colleagues, people that are doing phone and video? How do we improve their satisfaction? And a lot of it does come down to working conditions. Interpreters being able to dialogue with leadership, like that I will need a brain break. And the Pomodoro method is fabulous for this. They just released more research that they did prove that, after 25 minutes of hypervigilance, like intense concentration, you need at least a 5-minute brain break. After 50 minutes of hypervigilance or intense concentration, you need at least a 10-minute brain break. And they proved it by looking at I hope I'm saying this right, 2 different groups that were, one given the brain break, my terminology, I'm sure they said something a little more sophisticated, and the other group not given the brain break. And the group that got it answered questions more successfully than the group that did not. So continual hypervigilance and concentration in interpreting, could yield problems. And so having that improves satisfaction by having interpreters be able to dialogue and say, listen, I need this. And I can certainly say on my team, we have this, we can talk and make sure the dispatcher is aware of what kind of day we're having. But I think in addition to that, just looking at other aspects of our job that could be improved, things about what we do physically. I walk around a hospital all day. I love getting my steps, but I know that I interpret better when I'm sitting because I can concentrate. I can also do my notes a little bit easier, so I can do them when I'm standing. But I have a little stool that I bring with me everywhere. It's a little camping stool, and many of my colleagues also have one. And there's various different versions, but I just the one I have, it has a strap, and I love it. But it allows me to again have an aspect to my job that allows me to function in a way that I need to, and it also creates perfect physical alignment. So I also do it for the sake of trust with the family. I'm too tall. And if I were just to stand over a mom who's very short statured, I'm sure I'm going to lose a little bit of trust in that process because she has to keep looking up at me and it's not as comfortable. So I do try to sit as well for that reason. And that's another element of all of this. There's a million different strategies that we could do to improve satisfaction and to improve working conditions, which ultimately will improve satisfaction, but it's a cycle. The more you help interpreters be aware of their value by giving them a chance to tell you what their day's been like, that in and of itself says a lot about management, but then also giving them the working conditions to do it well, having brain breaks, having the ability to ask for that. All of that is key as well. But from a money standpoint, I think this is a very interesting thing that has also been an outgrowth of the research. And from a status standpoint, and I've mentioned this in a previous podcast, that Johanna Parker, one of my fellow commissioners on the CCHI, mentioned this in one of her keynotes, that healthcare interpreters, and I find this ironic because the job can be quite demanding, especially in certain settings and on certain days and with certain parties and certain characteristics, but we are the lowest status from the standpoint of our working conditions and our pay in general across the country. And I think if
is this in comparison to other interpreters, or is this in relation to healthcare employees?
Well, in relation to, and Johanna's comment was in relation to conference, legal, healthcare, and she actually does all three. And so in many ways, it says a lot, and what it says, I think, on the surface is, okay, we're misunderstood. And we kind of misunderstand ourselves as well. I think in a lot of ways, we need to be valued more. We need a higher status, but we also need to understand what we're doing so that we have a better recognition of how impressive our brains are. Because most of us just do this job and many of us love it. But we don't often realize that how misunderstood we are and how much we don't fully realize the value of what we're doing, and I mean, not just the skill set and the knowledge, but the ability to be a part of somebody's health outcome and a positive part of it. It's huge. But I listened to one of the podcasts that you guys put out during the pandemic by Sandro Tomasi, and it was on advocacy. And I thought, okay, that's good. I'm not quite sure where this will go. Is this advocacy for us, like advocating for ourselves? Is this one of those conversations we're going to have on what appropriate advocacy is for patients? And it kind of blew my mind. I was at the hospital. It was in the middle of the pandemic. I don't remember quite when. And he talked about, looking at pay for legal interpreters and doing comparisons between state and federal, also looking at court reporters. And I just was listening to it. I'm sure my jaw was open. I just was sort of happily shocked. But what he talked about was very interesting to me, because I realized not only are we misunderstood and we misunderstand ourselves, but there's not really much transparency about what appropriate pay is. And we get a little lost in, okay, wow, they make this much in this state and we make this much here, and freelancers make this amount. It's not apples for apples. So we're never getting a really clear picture. You have to look at it within the context of the cost of living. But what I've noticed for the states that do publish their wage on their website, like say a particular hospital, and there are some that do, and they say this is starting to midpoint, right? There is almost unanimous, if you consider cost of living with all this, there's almost or it's consistent, that we are online with customer service. And so, yeah, and we wouldn't know that because, nobody tells us, oh, hey, Joey over there, he makes this and she makes this. We don't know that. We don't talk about what we make quite like that. And some places don't publish it. But when I looked, that's what I realized. And I thought, okay, that's a problem. But again, it's ignorance. I don't think it's malice. It's just, they just think we're really nice and we speak Spanish, or we speak Arabic, and they're like, she's so nice. And so my first thought is, okay, yeah, we need to fix this. We need to understand our value and understand our skill set better to advocate for it. But what Sandro Tomasi said was concrete. It's beyond I think I'm valued at this rate and I want to get paid. He actually gave a very concrete piece of information that I did confirm. I have a good friend who's in the language acquisition field. She's at Auburn, that if you just take a look at language acquisition and what it is worth in the compensation package, or what it should be worth in a compensation package,
Well,
you're looking
define
at,
language acquisition for our viewers.
oh, yes. So language acquisition and the field of language acquisition are essentially professionals looking at what it takes for you to learn a second language. What does it take for Andrea to learn Korean? What will it take for Maria to learn Arabic? And the standardized knowledge is that it's between 5 and 8 years of immersion in that language. And so, not just academic study. And so that is the first piece of information that I had ever been exposed to that made me realize we're missing that. And I did do management for 6 years. That was the way we hired was extremely what's the word? Methodical? That sounds, yeah, methodical. I was extremely strict. You look at the years, so-and-so's done with academic work. You look at the years she's been in the field, and, it's roughly 3% per year. I mean, I went through it so many times with all the hiring that I know it well. And I realized that is one piece that if we were to add that at most facilities, like these facilities that I said that I've looked at across the country, the ones that publish, that could be the piece that bumps that role or that pay range for that interpreter or for that particular position up in a way that's just objective. But in addition to that, so I've never been so thankful for a podcast. I just thought it was amazing. And, I don't know where the field will go with this, but I do think there's a lot of my colleagues out there who are loving this job, but very, very much struggling to pay the bills. And, the cost of living right now and rent is just insane. And I live in a cheap city, like Atlanta is considered on the, it's not, the cost of living here is pretty decent in comparison to, somewhere like San Francisco. And so I hope that can go somewhere. But the other thing that I found when I was reading Atul Gawande, he's a fabulous surgeon who's written 4 books. I keep wishing I had his personal email so I could be like, could you write a 5th? Because I don't have anything to read. They're really, really fabulous books if you like the medical field. But in one of his books, and I think it was in Better. So there's Better, Checklist, Manifesto. I think it's in Better. He talked about looking, and I have no idea why this came up, but I, quickly dog-eared the page and have held on to it since. But Dr. Shao at the School of Economics at Harvard had looked at reimbursement for Medicare. And they were trying to come up with a standardized approach to quantifying what physicians deserved as reimbursement from Medicare. And he went about it from the standpoint of looking at it with 6 factors, and it was a bit of a rubric, and said, if you can essentially come up with a fair reimbursement, like for, say, an in-office procedure, maybe you have a toenail removed versus a surgeon doing orthopedic surgery. It took 4 hours. How do you come up with a difference between what their reimbursement should be? And he looked at it from the standpoint of a 6-point rubric. He basically said to figure out what the pay should be for these particular procedures and these particular level of specialists. You look at judgment, mental effort, physical effort, stress, technical skill, and time spent. The only thing that we look at in the field, at least from the standpoint of productivity, is time spent. And again, that doesn't necessarily yield as much of a pay or reimbursement to the interpreter as they deserve, especially when you think about freelancers. But it's an interesting opportunity. Like, if there is someone out there that would love to do an analysis like this for interpreters in healthcare, I would be thrilled, because they could look at it. And each environment's different. Nurses work in different environments as well. And some interpreters may merit a much bigger pay because of the environment in which they're working. Think about some of the cancer centers across the country, like Moffitt Center in Florida, St. Jude's. Some of those areas might, potentially, because of that rubric and the analysis of those 6 factors, that might yield a higher pay, or areas where the disruptions are exceptional. But I think between what Sandro shared and between me happening upon that in a random book, I feel like we are maybe at a crossroads where somebody somewhere might be able to say, hey, I have like a PhD student who's looking for a project. And that would be the beginning of it. Somebody who's willing to say, I'd like to look at this. I'd like to improve patient care by improving the satisfaction of these incredible interpreters who are relaying information that plays a huge part in their outcome. Like somebody that actually, understands economics and understands how important it is to get fair pay in healthcare.
And I'm certain that the results from your research would be useful in informing such a project, right?
I think so. I think the tool, yes, yeah, and it'll be out there soon and free. But yeah, it could be one way of quantifying that environment over time. And ideally, and I'm not sure if I said this, that the tool would, Vanessa Costa has said it this way, which I think is wonderful, that it could be used initially as a diagnostic tool to get a reading, get a sense of what's going on your team over this first quarter. And then over time, it would be used weekly, if not daily, for management to be really aware of the fatigue going on the team because of the score that's putting out. And that gives her as a manager or him the opportunity or they to say, okay, I need extra staffing, or I need at least an extra PRN this week because we've got too many things going on and we're not meeting the need. But yeah, it could be used for that particular analysis because you can see in different environments the level of demand and the cognitive effort, which would merit better pay.
So when will we be able to read the results? When will you be publishing?
So, God, I wish we would have published last year. So last year we tried to publish in several journals. So you have to do it one at a time. And we learned some things in the process. One of which was that we needed an extra analysis. And so Scott Gillespie at Emory is working on that. And then after that, the manuscript will need to be polished a bit. I'm going to work with a committee called the GEMS Committee, I believe, at Emory, just to make sure that everything is a little more solid. Last year, when we tried to publish, we had places tell us that wasn't a good fit, but one particular journal said, it could be a good fit, maybe, but you're missing this. And this would provide more rigor, like the manuscript would be a little more solid. And so hopefully we will be able to submit to the first journal. It'll probably be more of a working conditions journal.
So it seems like the publishing world doesn't really know quite what to do with research on interpreting. So you're, again, breaking into a new field, which hopefully will continue to yield some more positive results for interpreters.
Yes. And I think we need to find a journal, and of course it'll be peer reviewed, but just one that this fits in it better. And I think last year we chose patient care journals, and even though this does impact patient care, it's kind of an indirect impact. And so I think we're gonna try for something that publishes things on working conditions or metrics or tools that look at improving safety for workers.
Well, Andrea, we really look forward to seeing your work in print, and definitely keep us informed of when the tool becomes available so that us lay interpreters can check it out.
Absolutely.
And thank you very much for joining us here on Subject to Interpretation. Really appreciate your time.
Thank you. I really appreciate your time and this opportunity. Thank you.
To our listeners and our viewers, thank you so much for joining us here on Subject to Interpretation. Don't forget that this is the 25th anniversary year celebration of the De La Mora Institute of Interpretation. And we're also celebrating with the Founders Series, a special series celebrating the accomplishments of those individuals who have shaped this industry and they're sculpting its future. So don't forget to check out our other episodes wherever you get your podcasts. Until next time, never stop learning.